This is the Scalpel Finger Bougie Tube Cric Training Module. You'll need to utilize full PPE for this procedure. A mask with a face shield is essential. This procedure may be considered aerosolizing, so choose PPE according to current guidance. At this time, we'll assume you made the decision to perform the Cric procedure, the patient having met the inclusion criteria and lacking any contraindications. Take a few seconds to assemble all of your equipment before you begin the procedure and have an assistant available to hand you supplies and manage the ventilations. Your patient is likely in a can't intubate, can't ventilate situation, but choose your BVM to the best of your ability to optimize pre-oxygenation. Waveform capnography is mandatory for this procedure and can be pre-connected to the bag and monitor. You'll need a cuffed endotracheal tube to perform the Cric. A 5.5 tube is the smallest that will work with a standard Bougie and allows for the easiest passage through your incisions. A 6.0 cuffed tube is acceptable, but slightly more dissection through the neck will be required. Obtain a 10 cc syringe and check your cuff integrity in the usual fashion, deflating it once testing is complete. A Bougie is a useful airway tool that is essential to this procedure. It has an angled tip, which will be inserted into the patient and is used to guide the tube into position. Take your endotracheal tube and insert the flat end of the Bougie into the cuffed end of the tube. A 5.5 tube with its tight fit may meet some resistance, but with firm pressure will slide down the Bougie. Once you have a free end available, it's easier to pull the Bougie through the top of the tube. Advance your Bougie through the tube, leaving roughly 1 fist's width at the top of the tube, and the remainder through the cuffed end. This long portion of Bougie is what will be inserted through your surgical site into the trachea. Set your Bougie and tube assembly aside. You'll need a scalpel for this procedure. A 15 blade is most useful as you'll need to perform both cutting and stabbing techniques during this procedure. With one hand, locate the cricothyroid membrane. Use your index finger to palpate the membrane. Use the remainder of your hand to secure the neck structures on both sides of the membrane. Palpate the cricothyroid membrane several times with your index finger so you may develop a sense of muscle memory of its location. This is a blind procedure and you'll be using your sense of feel to find the landmarks. Uncover your scalpel and move your index finger clear. While stabilizing the airway, make a several centimeter vertical incision midline the neck extending above and below the cricothyroid membrane. Keeping your finger clear of the blade, use your index finger to dissect down to the cricothyroid membrane. Once you've palpated the membrane thoroughly, remove your finger. Make a stab through the membrane with your scalpel and make an incision horizontally to one direction. Turn your scalpel 180 degrees and cut through it in the other direction. Remove your scalpel and place your index finger into the patient's airway. Using your finger as a guide, place the bent coude tip of the Bougie into the airway. The Bougie should advance about 10 centimeters and then stop around the area of the carina. If your Bougie only advances a short distance, you are likely stuck in the neck tissues and need to reevaluate your incisions and the airway. If your Bougie extends much further into the airway than expected, you have dissected into some deeper structure and most definitely need to reevaluate your procedure. Once your Bougie is correctly inserted, slide your endotracheal tube into the airway along the Bougie, passing the balloon and the placement marker just inside the opening. Inflate your balloon and remove your bougie. Attach your bag, ventilate the patient, and verify placement with waveform capnography and the other usual methods. Have your assistant bag the patient, mindful not to overventilate. Keep respiratory rates at 8 to 10 or 12 a minute with a 400 to 500 ml breath volume. Avoid hypocapnia when possible. Secure your airway with tape or with a commercially available tube holder. Dispose of your scalpel in a sharps container. For ease of patient transport, you may wish to shorten your endotracheal tube. The tube may be cut with a pair of scissors. When doing so, be sure to retract and avoid cutting your balloon tubing. Continue to ventilate your patient appropriately and move on to other patient care needs.